Save. Okay, murmurs. So, 1 second. Um, Murmurs are huge. Um, I do apologize if I say things that you already know. This is kind of geared more towards like a physiology review, anatomy review. But I think it'll be good because these are super high yield. Okay, so murmur, turbulent blood flow. That's literally what a murmur is. Another name for a murmur is a bruit. They're all the same things. So, in terms of diagnosing, things you need to kind of pay attention to, like when you get a murmur question, like you realize this is a murmur question, where's the murmur located? So they're going to give you a little bit of about like auscultation, like oh, left second intercostal space, whatever. When the murmur is heard, so is it heard in systole? Is it heard in diastole? What the shape is, they don't give this all the time, but a lot of the times they'll say like, oh, there's a crescendo, decrescendo murmur. Buzzwords, which I'll point out, it's like opening snap, mid systolic click, that type of stuff. And then the maneuvers. I highlighted the maneuvers because the maneuvers are kind of tricky, but they like to ask about maneuvers because they're very fit, like they focus a lot on the physiology. So we'll talk about the that. Okay, so systole is when the ventricles are contracting, and then diastole is when the ventricles are open. So how I kind of tell people to like approach murmurs is kind of think about these two processes. So with systole, the ventricles are contracting, you're trying to get blood to the rest of the body. So that's when the aortic valve and the pulmonic valves are both open, right? So from the right ventricle, it's going to go to the lungs through the pulmonic valve. From the left ventricle, it's going to go to the aorta through the aortic valve. In systole, though, since we don't want backflow into like the atrial chambers, the mitral valve and the tricuspid valves are both going to be closed. Diastole, it's the opposite. We're actually trying to fill from the atria, so your mitral and tricuspid valves will be open, and then the aortic and pulmonic valves will be closed. So what if I just showed you this picture of this cross section of a heart, and you had to identify what these valves were? Could you tell me?
So the one with three is the tricuspid,
Okay.
and then the other one is mitral,
Okay.
and then I think the one in the front is I forgot, but I think might be like the aorta,
Okay.
and the other one is the pulmonary artery.
Okay. Good. So, just like you said, I forgot the order that I had this animation, so I didn't do it. Good. So the one in like the back, I guess, is going to be the pulmonary artery. This is going to be the aorta, mitral valve, tricuspid valve. So tricuspid valve's on the right side, so this is the right side of the heart. This is the left side of the heart. So this is kind of, you have to kind of imagine that this is a cross section of the heart, and now we're looking at the heart as if we're coming down, looking at it from on top. Okay. So the aorta is going to be the one in the middle. Is this heart in systole or diastole?
It's in systole.
Good. Awesome. Because the aortic and pulmonic valves are open, tricuspid mitral are closed. Okay. What about this one? What valve is this up here?
That's the pulm. That's a
Yes.
pulmonary. Yeah.
Yeah, it wasn't a trick question. It was just I kind of reversed the order of the heart. Well, not reversed it, but I changed it a little bit. And then same thing. So everything's in the same order. So now is this heart in systole or diastole?
Diastole.
Mm-hmm. Good, because the mitral tricuspid's open, aortic and pulmonic are closed. What if I flip the heart like this? What valve is this?
Tricuspid,
Mm-hmm.
mitral,
Yep.
aorta, and then pulmonary.
Yes, good. Okay. So even if we flip it around, the pulmonary valve is going to be the one furthest away from the other two valves. Good. So you can think of like, and this will help with like some cardiac path when you get to like cardiac embryo. The pulmonary valve is all in like a cross section like this is going to be more anterior, like than the aorta. So no matter which way you flip it, it's always going to be more anterior than the aorta. Okay. Okay, so then tying this into murmurs. So murmurs, there's like different types of murmurs you can think about. There's stenosis murmurs, regurgitation murmurs. So stenosis murmurs, these are called forward flow murmurs because when they flow through the valve, that's what's causing the murmur. Regurgitation murmurs are backwards flow murmurs because when they flow backwards, that's what's causing the murmur. Then you have mitral valve prolapse. We have HOCM or hypertrophic obstructive cardiomyopathy, a VSD, and a PVA. So this is auscultation. So I don't know if you know like the APTM mnemonic. This is like a first year thing. Me and my friends thought about it with all physicians take money. So in terms of like where the areas are. So the just in terms of like locations that they're telling you when the doctor's auscultating, the aortic valve is the right second intercostal space, or they'll say base of the heart. Pulmonic valve, left second intercostal space, tricuspid valve, left fourth intercostal space, and then mitral valve, left fifth intercostal space. Or for the mitral valve, they might say even the apex of the heart. Okay. And then again, it just kind of helps you because like a lot of the times they'll tell you where they're hearing the murmur and you kind of need to rule out certain ones if you're not in the right spot. Like if you're on the left side of the heart, it can't be an aortic, it can't be like an aortic stenosis or something like that because
So
the
like
aortic valve's on the other
sometimes,
side.
sorry, I just wanna like for aortic, I've like seen these aortic questions and then they'll be like, there's like, does it like radiate to like the left side or something? Like, or is there anything to do with the left
Um,
side?
so in terms of that, you have to think about the type of murmur. So if I have like a mitral regurg, it's going back from the left ventricle to the left atrium. So the murmur is sounding like it's going upwards, so it's going to sound like it's moving like towards the shoulder.
Got it.
I'll talk about that more. It'll help like when you see it. I'll talk about it for each murmur where you can hear it. Just in terms of like when they're talking about the specific like areas, it's like that's why I like this APTM thing is because it's like it's the area. So you can hear like aortic stenosis or you can hear like um no, that's not. It's like I don't know how to explain it. We'll talk about it when we get to each specific murmur. Hopefully it'll make sense. I think you need to visualize the murmur and then it'll make a little bit more sense. Okay. But so with stenotic murmurs, like I said, you're gonna hear the murmur on like forward flow, meaning when it's trying to open up the valve, because the stenosis is a narrowed opening. So again, if this is like what it's supposed to look like normally, this would be like a tube that's stenotic. It's narrowed. So in terms of stenotic murmurs, you can have stenotic murmurs during systole and you can have stenotic murmurs during diastole. So with systole, which valves are open during systole? Since again, stenotic murmurs, the issue is with opening. The issue with stenosis is opening. So what valve is open in systole?
The aorta and the pulmonary,
Mhm. And then what valves are open in diastole?
the mitral, and the tricuspid.
Right. So there's four types of stenotic murmurs. If you hear a stenotic murmur during systole, it's going to be an aortic or pulmonic stenosis. If you hear a murmur during diastole, a stenotic murmur during diastole, that's going to be mitral or tricuspid. And again, the reason why is because stenosis, you're trying to open that valve. So if I hear a murmur trying to open the valve during systole, just think what valves are supposed to be open during systole, aortic, pulmonic. And then same with diastolic. Diastolic murmurs, if I have an issue with opening the valve, which valves are supposed to be open during diastole? Your mitral and tricuspid. So first starting with aortic stenosis. So this is going to be heard at the right second intercostal space. Again, just like that's the aortic area. It's a systolic murmur. We talked about why, because this is a stenotic murmur of the aortic valve. So it's an issue with opening. When's the aortic valve open? Systole. So it's always going to be here during systole. It's crescendo, decrescendo, and I'll kind of explain that a little bit. And it's also known as an ejection murmur. Again, which kind of a few of the stenotic murmurs are known as ejection murmurs. But the crescendo, decrescendo, it's talking about like how loud it sounds during systole. So remember, systole is between S1 and S2. That's going to be your lub dub. Lub dub. Um, the aortic stenosis occurs between the lub and the dub, basically. And crescendo, decrescendo means it gets louder and then it gets quieter. And how I kind of explain people to think of like a crescendo, decrescendo is, yeah, sorry. Oh my God, like choking on my saliva. is to think of it like this valve is stenotic, right? So it's really hard to open. So imagine you, like this is supposed to be really easy to open with blood, but it's really, really hard to do that. So what happens is the blood tries to rush through it. It's trying to force all of its might to it to open it. And you can think of that as the crescendo part. It's like it's trying really hard, it's rushing really fast, it's getting really loud because it's trying to open up that valve. That's your crescendo. And then eventually it opens the valve. It eventually opens it. This valve opens up. And now that's your decrescendo. It's going to get a lot quieter after it's able to finally open that valve. So that's your crescendo, decrescendo. I always tell people, like, if you try to open up like a pickle jar or something and it's really hard, you're going like you're trying really hard, and then you get it and you're like, ah, and it's nice and easy. That's kind of like what the blood's doing. It's trying really, 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 really hard. It opens it and then it quiets off. That's your crescendo, decrescendo murmur. That's a classic aortic stenosis. Okay. With this, and this is just kind of like trying to tie it back into like like a Wigger's diagram, which we'll talk about in a little bit. But if the left ventricular pressure is going to be a lot more during aortic pressure during systole, which is not something usually that happens. Usually the left ventricular pressure goes to the point where the aortic valve pressure needs to be, and then it opens it nicely. This, it's going to be a lot higher than normal to open up the aortic valve. And then I always used old people are sad, my old people are sad mnemonic, because with aortic stenosis, typically you see them in like older patients, and then SAD gives you the symptoms. So usually people over the age of 65, if they present with syncope, angina, and dyspnea on exertion. So they might say that they're like passing out more often, they have chest pain, and then they have like shortness of breath when they try to like walk up steps. That's like okay, let's think about aortic stenosis. Pulmonic stenosis, never seen it, just really is not a thing. It's pretty much the same as an aortic stenosis in terms of like trying to open the valve. It's just one, it's at a different location. It's at the left second intercostal space. The only time I could think of you getting a pulmonic stenosis type question is in tetralogy of Fallot. There's that prove mnemonic, the P in tetralogy of Fallot, and it tells you what the tetrad is pulmonic stenosis. Okay. So that's really the only clinical time I could think of pulmonic stenosis. But it would present exactly like how the aortic stenosis murmur sounds. It would be a crescendo, decrescendo, systolic murmur. It would just be like on the left side now. Okay, mitral stenosis. This is at the left fifth intercostal space because this is your mitral area. This is a diastolic murmur, so it's going to happen after S2, before S1. Again, hopefully that is starting to make sense. You're like, okay, if this is a stenotic valve, it's a problem with opening. The mitral valve usually opens in diastole. It's going to be a diastolic murmur. There's an opening snap. That's your buzzword. And then there's what's known as the late diastolic rumble, which is also just another buzzword. If the open, and this is like kind of like something that they can bring up every now and then, if the opening snap happens quicker after S2, like it happens super, super quickly after S2, that means there's like the murmur is, not the murmur is worse, like the pathology state is worse than if it happened a lot later. Okay. And then here's your late diastolic rumble. All that really is once you get the valve open, now all the blood kind of rushes through, and that's what you're hearing. For this one, for like Wigger's diagram, the left atrial pressure is going to be a lot more than the left ventricular pressure because now it's kind of the same thing with like the aortic stenosis with left ventricular and the aortic. This is like the left atrium has to increase its like how much pressure it puts to open up this valve compared to normal. So it's going to be a lot higher than left ventricular pressure during systole. Sorry, during diastole, which is already a red flag because left atrial pressure shouldn't be higher than ventricular pressure during diastole. And then other like relevant things, if you have mitral stenosis, this is highly specific for chronic rheumatic fever. Okay. You can also have rheumatic fever occurring acutely, but usually that's going to present with an aortic or a mitral regurgitation. Okay, those are just like fun facts. Chronic rheumatic fever is mitral stenosis. It's highly specific for mitral stenosis. But if you have acute rheumatic fever, that's more indicative of like an aortic or mitral regurgitation. And then since the left atria is increasing in size, thinking back to like anatomy, the left atria is basically sitting on top of the esophagus. It's sitting, the recurrent laryngeal nerve kind of wraps through it. So you can get hoarseness, you can have dysphagia. You can also get AFib. Anytime you have left atrial enlargement, you can get AFib. And again, they think it's because like if you stretch out the valve, it's just gonna mess with the electrical system of the heart, and then it can just kind of trigger AFib. So tricuspid stenosis, exact thing, opposite side, and now we're in the left fourth intercostal space versus the left fifth intercostal space. And typically with tricuspid stenosis, you think of this with an IV drug user. And the reason why too is because if you're injecting drugs into your intravenously, all the drugs are going to first pull in the the right atrium, because that's where veins drain into. So if like, let's say you injected in like a bacteria or a yeast or something, the first valve it's going to come into contact with is the tricuspid valve. So that's why they typically say it's associated with IV drug users, and you can kind of use maneuvers to help differentiate it with like other certain murmurs. Okay, so those are stenotic murmurs. Now we have our regurgitation murmurs. So stenotic murmurs, issues with opening. Regurg murmurs, these are going to be issues with valve closing. So regurgitation, it's the same thing as insufficiency. So if you see like aortic insufficiency, mitral insufficiency, it's the same thing as regurgitation. It just basically means like, oh, the valve's not being sufficient because it's not closing all the way. And the regurgitation is like, oh, it's allowing blood to go back to the area like it was before. And then these are your backflow murmurs, so blood can now easily flow back through the valve it just came out of. So regurg murmurs, what valves are closed in systole?
The mitral and the tricuspid.
Mm-hmm. And then you have your aortic and pulmonic closed in diastole. Good. So for regurg murmurs, if you hear it during systole, it's either going to be mitral or tricuspid regurg, because those are the valves that should be closed during systole. And then diastole, if you hear regurgitation murmurs in diastole, that's going to be either aortic or pulmonic, because those are the valves that should be closed during diastole. So mitral regurg, this is going to be a systolic murmur. So we're in the mitral zone, so the left fifth intercostal space. It's hollow systolic, meaning that you hear it entirely throughout all of systole. It doesn't stop. And it sounds like a blowing murmur. So it sounds like like if you were to listen to it. And that's just kind of like a hollow systolic type thing. So it says it radiates towards the axilla, and this is kind of what I was like, I need to kind of help like have you visualize it to explain it. Since this is a backflow murmur and we're listening down here with our stethoscope, when blood pumps, most of it is going to go through the aorta, but some of it is going to go away back towards the left atrium. And remember, the left atrium is in the back, like it's sitting on top of your esophagus, like it's kind of like in the back of the heart, and we're listening to the heart down here at the apex. So it's going to sound like it's going towards like the shoulder, basically, or the armpit, because it's moving away from that stethoscope. Okay. So technically, like you're still listening here at the mitral zone, but it might just sound like it's moving away from you. But you'll still be at that mitral zone. So causes here, remember, acute rheumatic fever, chronic rheumatic fever is more of your mitral stenosis. Ischemic heart disease post-MI. So this is really interesting. This is like just like a cool fact. The RCA, so the right coronary artery, supplies. So usually in 90% of people, they're right dominant. And in those people, the inferior part of the heart therefore is technically supplied by the RCA, because the RCA supplies like the posterior descending, which supplies the back of the heart. The RCA also supplies the posterior papillary muscle for the mitral valve. So we have two papillary muscles for the mitral valve, and the posterior one, which is right here. The posterior one is supplied by the RCA. Just like a really interesting thing. So a lot of the times, I actually think I brought in a question to show you like how they would word something like that. But they'll say like patient has ischemic heart disease following an MI. And you should be automatically thinking like, oh, this is mitral regurg.
Wait, so like I had a question like that today and I got it wrong. Like,
It's tricky. It's like a tricky fact.
but like I thought that like isn't it like the circumflex or the LAD like isn't one of those like more likely to like get like this more like I remember like reading like somewhere that like those two like one of them is like more likely to be like blocked first or something.
Well, if you have like atherosclerosis, the LAD is the one, yeah, that would typically get affected. But this is like if you have an MI for like, let's say you have like a posterior wall MI or something like that, or if you have like an RCA MI, like one of those arteries gets blocked. The RCA actually supplies the back of the heart, technically, because it's the one that's feeding the PDA, and the posterior papillary muscle, so one of these two, is supplied by the RCA. So if you have an RCA heart attack, you're gonna get mitral regurg because one of these papillary muscles is just not gonna work, and it's not gonna be able to close the valve because it's just gonna be dead.
Got it. So like with MI, wait, I forget if we said this, but is there like one area that's like more likely to be affected before the others?
Um, I I don't, in terms of questions, I don't think so. That's kind of what they give you like an EKG for. And it's like, oh, realizing there's like ST elevations in leads 2, 3, AVF. That tells you there's a posterior wall MI, and you can see it on an EKG. So it's kind of like going off of the EKG leads to figure out like which one. I'm sure the LAD is the most common, and then the circumflex, and then the posterior wall. Actually, I think that is the order. I think it's LAD, then circumflex, and then like RCA, PDA. But I don't think it matters like in terms of like questions. I think it's just something like if the patient has an MI, you should just kind of, and now they have a murmur, you should think it's mitral regurg.
Got it.
Okay. And it's just one of those rare posterior wall MIs. And I'll show you when we get to that question, I'll kind of show you and you'll kind of see like how they word it. But it's a classic like trick question for mitral regurg. And then other causes, let's say you have mitral valve prolapse. Over time, eventually the prolapse will turn into regurg. Anything that's going to dilate your left ventricle can actually cause mitral regurg because again, the papillary muscles, like it's in the left ventricle. So you can imagine if this dilates, it's going to pull these leaflets with it, and then you can get regurg. And if you have endocarditis, that can also cause regurg. You can just have calcifications on this valve that's going to cause, obviously, issues with closing. Tricuspid regurg. So this is, again, I kept the same picture because it's the same thing. Everything's the same. It's just location is different now. So left fourth intercostal space versus left fifth intercostal space. Everything else is the same. Systolic, hollow, it's a holosystolic murmur. It's a blowing murmur. So how can you really even differentiate between the two if they don't give you location? Maneuvers. One, your tricuspid regurg is still technically a right-sided murmur, and mitral regurg is a left-sided murmur, even though you hear both of them on the left side in terms of auscultation. And then this is just kind of showing it. So with regurg, some of the blood's going to leak back into the right atrium. Causes of that, remember acute rheumatic fever. So acute rheumatic fever is going to be your aortic and mitral regurges or tricuspid regurges. And then your chronic is going to be your mitral stenosis. And again, if you have right ventricular dilation, so again, the papillary muscle is anchored in the right ventricle. If the right ventricle dilates, it can pull the valves with it, and then you can get regurg. Okay, aortic regurg. So we're going to be back in that aortic area. So right second intercostal space, the aortic valve should be closed during diastole. If it's not, you can hear a murmur, and that's where you hear it. You hear it after S2, before S1. And it's an early decrescendo. So it starts loud and then it gets softer. And it's also considered a blowing murmur. But for this, how I kind of explain like early decrescendo is So you're still listening to the heart. Like the heart is still pumping out blood. It's still pumping from the left ventricle to the aorta. It's just some of the blood kind of rushes back through the aortic valve. So imagine like like a roller coaster when you're going up a roller coaster and then you get to the top and then it's like, ooh, you're right there and then you fall back down and then you start going back down after that. That's kind of how I think about this. It's like so when this pumps out blood, the blood that's like right here, so it's pumping it out, but now it can actually leak back. The blood that's closest to like the valve that's open, like this leaky valve, is gonna rush back in. It's just gonna completely rush back in. That's your loudness right here. And then it kind of trickles off because then the pressure's high enough that no more, like, not all the blood you just pumped out is gonna come back in. It's just some of it. So it's kind of like that's what this decrescendo. At first, it's the blood that's right here, and it comes back in really fast, just like a roller coaster, and it comes back in, and then it kind of trickles off. So that's like a decrescendo. I think of it as like the pressure's so high, it just like brings it back down. Your mnemonic for common causes for aortic regurg is your Bear mnemonic. So Bear is bicuspid aortic valve. This is super common in Turner syndrome. You probably are even getting questions on that. Um, Yeah, bicuspid aortic valve is super, super, super common in Turner's. And the reason why with bicuspid aortic valve, hopefully that makes sense. Your aortic valve it's a semilunar valve. It should have three valves. So now if you have two valves doing the work of three valves, you can imagine that one of them is going to become insufficient. And then it's just you're not going to be able to close it all the way.
So for Turners, they were also like I had a question today on
Yeah.
like Turners and like coarctation.
Yeah, that's also coarctation of the aorta is also associated with it.
Is coarctation also associated with like bicuspid valve, like all three of them together, or no?
Not usually not. They'll usually probably only give you like one or the other in a vignette.
Okay.
Sometimes maybe, but I don't think like I at least in vignettes, I don't think they do that. I think they'd give you like one or the other. Okay. Endocarditis can cause this. Aortic root dilation from syphilis can cause this. So if you think about, so syphilis is technically a vasculitis. I think it's so interesting. It actually just like eats away at the vasovasorum. So if this is my vessel, there's the three layers of my vessel. We have the adventitia, the media, and the intima. So this is the lining of my vessel. I have endothelial cells here, endothelial cells. Then I have my intima, my media, and then my adventitia. So intima is innermost. I My media is in the middle, and then my adventitia is out here. Out here, we have vasa vasorum, which are just little arteries that supply blood to this artery. It's kind of like, yeah, it's an artery, it's bringing blood places, but it needs blood itself because it needs blood it needs oxygen too. So that's what the vasa vasorum does. The vasa vasorum kind of supplies these arteries blood. And literally, vasa vasorum means like blood vessel of blood vessels. So syphilis is actually a vasculitis of the vasa vasorum. It actually kind of takes out the vasa vasorum. It just takes it out. And then the layers, obviously, that are further away from it are the ones that are going to be most at risk. And since the muscular layer of arteries is the one that has like the smooth muscle cells, it's the one that's doing the most work, it's going to be experiencing the most like loss from not having oxygen. And then what basically happens is that's when you get like that tree trunking appearance, and that's when you get like basically you get like ischemia and fibrosis that's happening when you have syphilis. So syphilis is technically as a vasculitis. Syphilis also causes tabes dorsalis in the neuro column. It kind of does the same thing. It kind of like causes, it's not like a vasculitis, but it causes like a neuritis of the dorsal column. So syphilis is tricky, but it causes aortic root dilation because since we now get like tree trunking, which is just like crazy fibrosis and like thickening of the aorta, it actually can like dilate the where the not dilate, but like where the root is. So actually I'll just point it to here. Right here. This is the aortic root. Since it's kind of messing with the rest of the aorta, like out here, it can actually cause dilation of this and make it like wider apart, and then it doesn't close as nicely. That's my long-winded aortic root dilation for syphilis. Syphilis is a vasculitis. And then rheumatic fever can also cause aortic regurg. Usually it's going to be your acute rheumatic fever.
So like the valves also have like the three layers.
Yeah, everything. No, the valves themselves don't, but for syphilis, it's going to affect the aorta, which this is going to get like thicker, like this is going to get thick and fibrotic, and since it's getting thicker and fibrotic, it's going to just expand and it's going to basically pull this apart.
Oh, I get it.
You get what I'm saying? Like the tree barking is going to happen like over here, but since it's getting thick, everything's connected. So it's going to even widen this.
That makes sense.
Syphilis. Okay, and then some clinical findings, the hyperdynamic pulse. This is something that I guess hyperdynamic pulse, widened pulse pressure is a better way to think about it. It's just like the pulse pressure is going to be a lot different. And the reason why, like, there's going to, like, from what it should be, it's going to be a lot wider because the aortic pressure and oh my God, the aortic pressure and the ventricular pressure are going to be a lot different. And I'll show you that as well on the Weger's diagram. How that usually manifests is like you look at the left ventricular pressure and you look at the left the aortic pressure, and it's gonna be a lot bigger of a gap between the two. Like if this is the start of the aortic pressure, this is the ventricular pressure. If I have a widened pulse pressure, it might look something like that. Like it's just gonna look widened. And again, it's just due to like more blood now flowing out of the aorta back into the ventricle. So it's just gonna, yeah.
So like hyperdynamic pulse literally means the same thing as the widened
Yeah,
pulse.
they're like the same thing. Yeah.
Because I've seen it written like that and I just don't know. Like,
Yeah. Yeah, hyperdynamic pulse is that's pretty much what it's saying. It's just like the pulse changes so much, but it's changing because there's a widened pulse pressure. They kind of go hand in hand. And then the head bobbing is literally because like the aorta, it's like right here. So there's all this pressure going through the aorta and then it's coming back into the ventricle. And then the next round, there's going to be extra blood basically in the ventricle getting pumped out. And that kind of repeats over and over again. So there's such a high volume of blood getting pumped out every time that people say it looks like your head is bobbing just because it's like blood, blood, blood every time your heart beats, which I'm sure that's an exaggeration, but that's what it'll say in a vignette. They also might say I've also seen like pulsating nail beds or something like that. Just like yeah, something like that where it's trying to represent that every time the blood is pumping now, more blood is coming out with it. Because like we have the normal blood, let's say we're supposed to pump out 3 liters every single time it beats. So we're going to pump out the normal 3 liters, but if we have regurg, let's say half a liter comes back. Now this time I'm going to pump out 3.5 liters and then half a liter is going to come back. So then from there, it's going to be every single time I'm pumping out more than usual.
got it.
Okay, pulmonic regurg, again, just like pulmonic stenosis, literally never seen a question on it. It would present exactly the same as aortic regurg, but we're in the pulmonic area, so you'd be left second intercostal space instead of right second intercostal space. And you would just use maneuvers. You basically use maneuvers to distinguish between like left-sided murmurs and right-sided murmurs. Okay. So then after this, the stenosis, the regurg murmurs, there's special murmurs. They get their own slides because they're special. But the ones that occur in systole is mitral valve prolapse, your ventricular septal defect, and HOCM. And then there's a continuous murmur. That's your PDA, which we'll talk about. Okay, so mitral valve prolapse, I actually think this is like a tricky, kind of like a tricky murmur to like visualize what's going on. I've tried to find a lot of images to help you visualize it. I think I can explain it nicely though. So see, the mitral valve is kind of weird. The mitral valve when it closes, it kind of balloons up, like if these are the two leaflets. When I want to open it, they go like this. They kind of like go up and out like this. And then to close them, they come together like this. So it's like opening, closing, opening, so like diastole, systole, diastole, systole. So they kind of go like up. I literally think of them as like little balloons. Like they go up and then they come back down. They go up and they come back down. If you have a prolapsed mitral valve, that means it doesn't close nicely like this. When they open up and they come back down, they don't fit perfectly. It kind of fits like this. It's still closed, like the valve is still closed. It's not insufficient. But now it's like instead of having a perfect seal like this, it kind of goes like this. It's like an imperfect seal. And that's your prolapse. Prolapse literally means it's just like I don't know if it's prolapsed. It's out. It's out of like where it should be. All right. This is the best slide. I know that this is a really weird, I don't know who this like superhero is here in the background of this slide. This is the best slide I've seen though on mitral valve prolapse, so I wanted to put it in here, but again, no clue who this woman is. But I like it because this is a really good, this one right here. Great picture of mitral valve prolapse. So see again, so like this would be like the posterior leaflet, and then this would be like the anterior leaflet. And technically, this is closed. Like, if this were to be open, blood would come through here, right? It would come up through these two leaflets. So technically, it's closed. It's just there's a part of like the posterior leaflet that's like doesn't perfectly sit in the groove. It's like prolapsed back. So it sits like kind of imperfectly. And I just think this is a really good way to kind of visualize mitral valve prolapse because it is kind of like a really weird murmur. Does that make sense so far? So they don't open like how you would think with like normal valves. They kind of like open and close like a balloon, and then prolapse, it's like part of one of the leaflets is like not perfectly in line with the other one.
Could like blood still like flow through if it's a really bad mitral valve prolapse?
I think when that happens, it's eventually considered mitral regurg. And that's like why one of the causes of mitral regurg is mitral valve prolapse. Because like
Oh,
if you get prolapse to the point where it's so bad, then you eventually get your regurg, your insufficiency. Okay. So MVP. Um, so this is gonna be at the mitral location. So your left fifth intercostal space. This is a systolic murmur with a mid-systolic click. I'm gonna explain what is causing that mid-systolic click. This is the most common valve issue. If this is like one of those types of things where if you see like a young female athlete with a murmur, it's going to be MVP. It's the most common valve issue and the most common murmur. Okay, super, super common, especially your young female athletes. So there's that mid-systolic click, and then there's a murmur after it. So this is your picture. So this is like, again, imagine these two mitral leaflets. So normal, they come together, they fit nicely. I don't love this picture because it looks like both of them are prolapsed. Usually just one of them is like not fitting perfectly with the other one. And then eventually it can progress, like frequently it's going to progress to mitral regurg. Once you get like that blood backflow, that's when it's considered a mitral regurgitation. Okay, so the mid-systolic click. So the best way I can explain this mid-systolic click is looking at this picture. So the mid-systolic click technically is caused by the sudden tensing of the chordae tendineae. This is like almost like a need to, it's not really like a buzzword because it's not really like a buzzword, but that's what's causing this mid-systolic click. Sudden tensing of the chordae tendineae. Oops. So if we look at this, here's your chordae tendineae, these white things, and they're attached to the papillary muscle, which is right here. So remember how I told you how the mitral valve opens? It opens like this, and it comes back together. So imagine if you already have one of the valves already up like higher, so to speak. And then when you go to open it, it's like already up there. So it's already up a little bit higher. But now the one that's normal, when it closes, it's going to go back to its normal spot quicker than the one that's prolapsed, right? Because let's say this leaflet only has to go to, this like 1 centimeter higher. When it opens, it moves up 1 centimeter from baseline. This, since it's already starting higher, it's moving like 3 centimeters up higher when it shouldn't be. It should only be moving like 1 centimeter up. So when it opens, this valve is moving 1 centimeter up. This one's moving 3 centimeters up. And then when it closes, the papillary muscle needs to pull on it. The chordae tendineae is pulling on it. It stops when the normal valve should be stopped, which is about 1 centimeter. So it's going to stop. This other one is still now only at 2. Now it's moved down. It's still at 2 centimeters because that's its normal prolapsed area. So that's the sudden tensing that's going to cause that mid-systolic click. it like opens it when it tries to close all the way, and that's why you hear it during mid-systole, because it's like this one already finished closing, but now the chordate tendineae is like catching this other one that's still up here, and that's what's causing that click. Does that make sense? That's usually pretty confusing.
It makes sense. I just need to like watch it again and pick up on the little
Okay.
things.
Yeah. I think of it like I try to also explain it to people like if I were to throw you a water balloon, you would try and like cradle it. Like you would like cradle it nicely. If I threw you and this and I'll talk about this a little bit more with like when we talk about mitral valve prolapse with the maneuvers. But if I threw you a water balloon and you just caught it, you didn't cradle it at all, it's just gonna like break open. And it's kind of the same thing. It's kind of like with the chordate tendineae, it's not like nicely grabbing the prolapsed valve and bringing it back down. It's just like pulling on it because the other one's already done, and that's what's causing that click.
That makes sense.
Hopefully it'll make more sense when you go back through it. But just think of it like it's the chordate tendineae is gonna stop. It's gonna like stop pulling when the normal valve is in place. The prolapse valve is still gonna be higher than normal, so it's gonna be like that sudden tensing is gonna cause like a click. It's like, yo, why are you not back at normal? And it's just gonna tense up, and that's what causes that click. Okay. And then common causes of this is like an issue with like either the connective tissue or like the fibrin that's present like in this area. So they call that myxomatous degeneration. You'll see like Marfan syndrome and Ehlers-Danlos common causes for a lot of stuff, like even like aortic dissection. Marfan syndrome and Ehlers-Danlos are common causes of that because it's just like affecting the like the vessel itself, like the what the heart is made out of itself. Rheumatic fever can cause MVP. Again, rupture of the chordate tendineae post MI, kind of the same idea. That can maybe it's like a small MI, so it's only causing a prolapse rather than like a really big MI that's causing like that regurgitation right off the bat. And again, young female athlete, that's going to be your mitral valve prolapse. Okay, VSD, ventricular septal defect. This is going to be this is going actually I just wanted to show it to you just to visualize it, but this is going to be heard at the tricuspid area, and the reason it's heard at the tricuspid area is because technically again when you're thinking of murmurs, it's like where is the murmur. The murmur is going from the left ventricle back to the right atria, so it's going to kind of seem like it's moving towards the tricuspid valve. That's why you can hear it in the tricuspid area. It's holosystolic, so this kind of already looks like this guy, mitral tricuspid regurg. It's holosystolic. It's going to be throughout systole, but it sounds harsh. And I've seen this word a lot of the times, like as a buzzword for a VSD. It just sounds very, very harsh. It sounds really intense. And counterintuitively, smaller VSDs are louder than larger VSDs. And I remember a kid in my class said this during an LI, and I'll never forget it, is the smaller the hole, the bigger the thrill. So if it's a really small, hole, it's gonna sound a lot. You're gonna have a much like louder sound. So even in cardio, a thrill is like it's like a sensation of movement. It's kind of the same thing. If it's really small, it's gonna sound a lot louder than a very, very big VSD. So if one that went from like here to here, that would actually technically it would be a lot worse, but it would sound a lot better. It would sound like, oh, this actually doesn't sound too bad. That's not great. That means it's a really big VSD. So I like the smaller the hole, the bigger the thrill. I think that's fabulous, but that's for a VSD. I had this on my boards. They just basically described a VSD. I just remember this one so clearly because I was like, oh, I just read this before I took boards. Um, they described a VSD, they went through the whole motions, and then they were like, what was a risk factor in the mom, or what did the mom do to predispose herself to the murmur that was heard, and fetal alcohol syndrome. So the mom drank while she was pregnant. VSD is also the V in the proof mnemonic for tetralogy of flow. So we covered pulmonic stenosis, and then we have VSD here.
Real quick for
Yeah.
because I had like three questions on um tetralogy of flow,
Mhm.
and I just want to double check that like even though there's a VSD, because of everything else, that's the reason why. Like it's a right to left, right? Because usually I always think of like VSD as left to right, but I like for like the tetralogy of Fallot, like even from day one, it's always going to be a right to left, right?
Yes.
Okay.
Yes. And actually that is yes, and that's also why if for tetralogy of Fallot, there that's the one where they squat and they feel better, right?
Yeah, and
Yeah.
that like comes up all the time in
Yeah.
question.
Yeah. So I can explain it really quick. So actually, I'm just gonna draw my box heart. So with left atria, all right, that's good enough for now. No, you know what? I'm gonna use this guy. Yeah, I'm gonna use this one. Okay, so tetralogy of Fallot. Do you remember which of the prove? Which one is the one that causes the worst symptoms for the patient? So which of the four cause the worst symptoms?
Like the pulmonary hypertension.
Yes. So the pulmonary stenosis, which yes, pulmonary hypertension caused by pulmonic stenosis. So if you have really bad pulmonic stenosis, the patient's going to have really bad symptoms. If you have not so bad pulmonic stenosis, the patient will feel a lot better. And it actually has to do with this VSD. So imagine having pulmonic stenosis. This valve is really hard to open. So we have deoxygenated blood coming in, and now it's like it can't really go through the pulmonic valve. It's like, oh, like I can't really go through the pulmonic valve. It's stenosed. What it does instead is it goes right to left, which is what we you just had mentioned. So it's gonna go right to left, it's gonna go over here, and then it's gonna kind of like dilute this oxygenated blood, but it's fine. It's like, okay, let's go, and then it's gonna get shot out to the rest of the heart or to the rest of the body. With squatting, and we're actually going to talk about this today. I actually think I have that in here somewhere about squatting. Squatting, do you remember for squatting what that does in terms of like preload, afterload?
So it increases, well, I don't like, does it increase preload like when you're squatting? Because like
Yep,
as you
it
get up, it
increases
like,
preload.
okay, and then afterload, I don't know why, but I think
Yep.
afterload increases, right?
Yep. So it's going to increase preload, it's going to increase afterload. Squatting, like making tetralogy flow better, is because of its feature, like of increasing afterload. So if I'm increasing afterload, I'm basically, you can think of it too as like increasing, the amount of pressure that the rest of the heart has to push against. So like I think of like increasing afterload as increasing my TPR. So if I am now increasing TPR out here, I'm making it harder for blood to go to the rest of the body, right? That's kind of what afterload is. So now what you're doing by squatting and increasing that afterload, you're actually forcing the blood to stay in the heart. So I'm forcing the blood that just got pumped out to stay there because the afterload is so high. And then, since this pressure increases here, it actually reverses through the VSD, goes back through, it goes from left to right, and then it can go help open up this pulmonary valve. Now there's just going to be more blood here, so I'm going to increase the amount of blood here. So I'm going to increase, like, it's going to be easier now to push open the pulmonic valve and then go to the pulmonary, like, go to the lungs, get oxygenated, and go through that process again.
So like when you squat, does it always cause a left to right? Because I don't know, like when I was reading it, I just assumed that like if there's more pressure in the left ventricle, then that means that like less blood will flow that way, but this is shunt like always reverse, I guess.
So that's actually what makes so like babies that have tetralogy flow, like they don't know like, oh, if I squat, afterload is going to increase, which is going to reverse my shunt and then make me feel better. They don't know. They just do what feels good. So they squat. And like by squatting, that's what's happening is they're reversing this blood flow. They're putting more in this left ventricle and then they're basically reversing the shunt through the through this VSD. They're going the opposite way. So now that they have more blood in here compared to when they're not squatting, and now that blood can actually open up the pulmonary artery, and now they're going to feel a lot better because again, the pulmonary artery stenosis is what's causing most of the bad symptoms of tetralogy of Fallot. So if I increase the amount that I can open up that valve, the whole baby's basically gonna feel better.
Got it.
that make sense? So yeah, you do. That's actually why it's like, oh, during a TET spell, they squat and it makes them feel better. That's why. It's because you're reversing the shunt and you're making it easier now to open up that pulmonary artery.
Makes sense.
I'm pretty sure I have a picture of this later when I talk about rapid squatting. So we can also talk about that too. We can like go back through it. Was that your only tetralogy of Fallot question?
Yeah, literally every question I'm asking you like throughout this is everything I remember from like what I've
Oh,
been
good.
getting.
See, that's why it's good to do questions. It's good to do questions because they ask you important stuff. And then VSD, this is the most common congenital heart defect. Remember, the most common heart defect technically is MVP, but this is the most common congenital one. Hokum, this is kind of, oh, actually, this is going to be like perfect. This is going to be very similar to why babies feel better when they squat with tetralogy of Fallot. It's going to be very similar to Hokum. So remember with Hokum, it's like a genetic defect. So there's like an issue with a gene in these people. It can't just happen to anyone. There's a literal issue with the gene in the IV septum, and it just causes a very thick IV septum. And actually, before it was called hypertrophic cardiomyopathy, it actually used to be called like subaortic stenosis. I think it was called like hypertrophic subaortic stenosis. I forget. But because it basically looks like aortic stenosis, like the left ventricle needs to push the septum out of the way so that it can go through the aortic valve. So when answering questions, look for the vignette of like an athlete that dies suddenly, like on the field, if he's playing soccer, on the court, if he's playing basketball, with a history of sudden cardiac death in the family. They'll usually say like, oh, like this happened to his uncle or whatever. This is, yeah, like I said, this is a mutation. This is not due to like just a run of the mill type thing. This is a mutation. That's the whole genetic aspect. That's why they usually say like, oh, my uncle, like this patient's uncle also had the same thing.
Why do they always like use an athlete? Like, does sports make it worse?
No, because that's, and we will talk about it. Yeah, we will talk about it here. I'll put it here, athlete, so we talk about it. Just like with MVP, so MVP is a little different. Why it's like an athlete, like a female athlete, because with athletes, like they have to pump out more blood if they want to be a really good athlete. Like if you want to be really good, you have to get you. That's what conditioning is. Basically, when you like condition, when you run like 8 miles a day, you get used to like conditioning. You're conditioning your heart to be able to pump out more blood per beat. So certain things happen, like the vagal tone on your AV node actually increases. It's going to be in that video that David's going to send you. I literally talk about how why like first degree heart block is really common in athletes. It's the same thing. It's kind of like the vagal tone on the AV node tells the AV node like, hey, slow down the electrical signal from the SA node to the AV node. Slow that down so that the ventricles have a lot of time to fill, and then they can pump out more blood. For Hokum, if it's an athlete, the reason why is because like already this heart can't pump out as much blood as like a normal beautiful heart, right? It can't pump out as much blood. When you're running on the field and you need to increase your cardiac output like 80% when you're exercising, you could literally die because like the septum just completely blocks the output. Because again, think about why does the body need more blood when you're exercising? Why does your heart increase when your heart rate increase? It's because the organs are like giving off carbon dioxide. They need oxygen because they're working really hard. They need oxygen, so they need more blood. So if you block, so that's why your cardiac output needs to increase when you're exercising, and if it doesn't, they can die literally from like ischemia because they're just not getting enough. So in terms of like an athlete in this instance, they just mean anyone that's like running a lot, like doing something that would require a lot of blood, aka oxygen. Okay. But for this one, this is again a mutation in sarcomere protein makes the IV septum get very, very thick, and it completely mimics aortic stenosis. Everything about Hokum mimics aortic stenosis. Really, the only way that you can differentiate between aortic stenosis and Hokum is with the maneuvers. So again, you're seeing how important the maneuvers are. So like I said, Hokum, I even put the graph for aortic stenosis. It is literally exactly the same as aortic stenosis. Crescendo, decrescendo murmur. It's a systolic murmur. You can only tell the difference with maneuvers. You can
Wait, so
also get, oh, sorry.
I have one more question because I got
Yeah.
this wrong. This is like what I got wrong yesterday. With like I just thought decrescendo crescendo was like aortic stenosis, but like is there any way to tell this apart just by like age or like anything else? Like
It'll always be for hokum, it's always, always, always going to be a younger person that was doing some sort of physical activity. Always. Always. Even if it's I once saw a hokum question where it was like a student running from he was late for class, so he's running from his dorm to class and then he died. That was hokum because that's physical activity. That's physical activity. Aortic stenosis, that's going to be old people are sad. So that's going to be a 65-year-old man who has trouble breathing when he goes up steps. He's got angina, he's got like those sad symptoms. Whereas hokum's going to be like a young person, like in their 20s, running from their dorm to class and they just drop dead. So it doesn't have to be an athlete, it's just some sort of physical activity. And usually, like 70-year-olds aren't like running like 8 miles a day, usually. They wouldn't do that to you. They would give you like a younger person. They don't have to be super young. Like it doesn't have to be super, super young, but it's not going to be like a 75-year-old person that doesn't exercise ever.
that makes sense.
So you can get left ventricular hypertrophy secondary to the actual issue. So again, the actual issue is this left ventricular septum, like the septum itself is thickened. So now it's again exactly like aortic stenosis. This ventricle is trying to push this septum out of the way so that it can pump blood out through the aorta. But by doing this, it's going to get thicker over time. It gets basically you get left ventricular hypertrophy just like you would with aortic stenosis, and that's why literally it's an aortic stenosis like murmur. Oh yeah, here it is. Murmur used to be called IHSS, idiopathic hypertrophic subaortic stenosis, because it's so similar to aortic stenosis in like every regard, just in terms of like the type of person that gets it. But yeah, back to the athlete with this. Again, when you're exercising, when you're running, the muscles, the organs, everything needs oxygen. They need blood. You need to be able to increase that cardiac output. So when you increase that demand on the heart, it can't compensate because it really can't get this IV septum out of the way over and over and over and over again. And that's when they die. At rest, they're totally fine. And if like a patient knows that they have this, literally do not do not exercise. Like don't raise your heart rate whatsoever. Never raise your heart rate ever. Okay, and then ductus arteriosus. So for PDA, that's a continuous murmur. So in fetal life, I don't know if we've talked about this briefly, but in fetal life, remember you should know fetal circulation. For this exam, you should review that. There are three shunts in the fetal heart. This is one of them, the ductus arteriosus. So the ductus arteriosus, again, and the whole point of having these shunts in the fetal heart is because the lungs are not functional when they're developing. So they need to basically bypass the lungs. So remember with this, oxygenated blood is coming from the placenta, which is like down here from like mom, and then it goes through all the shunts, it gets to the heart. So oxygenated blood is actually coming in through the right atrium. It's oxygenated. Some of it goes to the right ventricle, some of it, and then it can go through the pulmonary arteries, and then it can go to the trunk. And because I mean the lungs are developing, they're still going to need some oxygenated blood. That's where that's going. But most of it goes directly through this shunt, the foramen ovale. It goes directly from the right atrium to the left atrium. So I can't really draw it on here because it's red on red. So that's the first thing that happens. And then it's going to go down here to the left ventricle. And then the left ventricle is going to go through the aorta. And then it's going to go to the rest of the body. So one, it's going to go to the rest of the body. But then the other one, it's going to basically meet up with any blood that came. So any of the blood that went from the right ventricle through the pulmonary artery and then it branched to the lungs, some of it is still going to go forward and go into the aorta and meet up with that blood. And that's why it looks a little purple. You're getting mixing of oxygenated and deoxygenated. So in fetal circulation, the ductus arteriosus is a right to left shunt. We're coming from the pulmonary artery to the systemic circulation. After birth, when basically, after birth, normally this closes, which is fine. But if it stays open, if it stays patent, that's when you get the left to right shunt. So that's when the shunt reverses. And that's what can cause a murmur. So that's your PDA. They say that this is best heard infraclavicularly, so just right under the clavicle. Continuous, they call it a machine gun murmur. I don't really know what that sounds like, but it's like a very intense, like it's just an intense sounding murmur, and it's throughout the entire heartbeat. It's through systole, it's through diastole. That's what's meant by continuous. And for your micro plug, congenital PDA, like a congenital PDA staying open, can be caused by rubella. So from having congenital rubella, if mom had rubella and then it transferred to the baby, that can cause the PDA to stay open.
Wait, why is it always like, why is it consistent like for all of them? Like for, I mean, sorry, like why is the sound present during systole and diastole if like the blood is flowing through the pulmonary artery only during um like during systole, right?
So technically, since again, remember this might be like an Anki card back from first year. I vaguely remember this Anki card. But do you remember with like your aortic pressures, it's like what's the max aortic pressure, what's the minimum aortic pressure? It's not zero. It's not like there's no blood in the aorta ever. So even during diastole, where it drop, I don't know if it drops to like 60, I don't know, 60 and 120, let's just say. So it maxes out at 120. That's going to be your heart, your like blood, your systolic blood pressure. And then it's going to drop to like, let's say you have 120 over 80. 120, it's going to be, 120. But then during diastole, when the rest of the heart is relaxing, your aortic pressure is still going to have around 80 millimeters of mercury in it. That can backflow. So you're going to get a murmur during systole and you're going to get one during diastole because there's always going to be blood in that aorta.
So like for VSD and ASD, like is that also going to be a constant murmur then if that's just like open or
No,
okay.
and the reason for that is because you only hear the murmur in that instance when the ventricle is pumping. That's what's going to cause that murmur. And it's not like it flows out and then during diastole it flows back the other way. It just kind of stays there. Like during systole, like the left ventricle pushing the blood and then some of it happens to like go through to the other side. That's causing the murmur. During diastole, it's just like this blood doesn't go back. It just kind of stays here on this side. It's like, okay. So there's no backflow of blood, so there's not going to be a second murmur during diastole.
Okay, that makes sense.
Versus here, like there is, just because there's so much pressure in the aorta just at all times that it can flow in and it can flow out. I think this is a really good picture to see it too, because it really looks like yeah, literally any single time there's blood in the aorta, it looks like even gravity is just gonna pull it down. Okay, the big guy, maneuvers. All right, so maneuvers are either, and I don't even think people use these clinically, but for vignettes, there will always be maneuvers for murmurs. I'm sure you're seeing that too when you're doing UWorld questions. Yeah. If you know maneuvers, you're like set. So maneuvers are either going to increase the intensity of a murmur or decrease the intensity of the murmur. And that's why it's really hard to just kind of memorize the maneuvers. It's going to be actually a lot easier if you understand what's going on with the maneuvers, and then if you understand the path, like what's causing the murmur, it'll hopefully help you like reason through it rather than just memorizing.
Mhm.
First year you could 100% memorize these maneuvers, but second year you really need to like sit and like think about these. So the ones to know are Valsalva or just standing, passive leg raise, rapid squatting, hand grip, and inspiration. These are the 5 maneuvers to know. So we'll start with Valsalva or even just standing. So Valsalva or standing decreases preload. So again, if I do standing, remember when I'm standing up, all the blood is going to pull in the veins like towards my feet. So that's going to decrease preload. Valsalva has like a whole, series of it has a whole series of steps. We can go into Valsalva could be like its own topic. There's a lot. There's like 4 steps to Valsalva, but when they're talking about Valsalva as a maneuver, it's when like you're literally in that main phase of Valsalva, like blowing against, like if you tell a patient to blow against a pen, like that to that point where like you're increasing that intraperitoneal pressure. You can think of that as almost like crushing. It's not what's happening, but you can think of it as like it's crushing the veins, so you're decreasing the preload that's going to the heart. Okay? So if I'm decreasing preload in the heart, that means I must be decreasing the amount of blood in the heart. If I decrease just the amount of blood in the heart, thinking about murmurs, murmurs is caused by blood flowing across these valves. Usually, most murmurs will get, how did I word it? Will decrease intensity if I have less blood present. Because again, what's causing the murmur is blood flowing. So if I just decrease the amount of blood, yeah, it's not going to sound as loud because there's less blood there. This is for most murmurs, not for all of them. But I, again, think about this as less blood that can now bounce around and be turbulent, make noise. So that's going to be a decreased sound. However, because MVPs like to be tricky, decreasing volume for the MVPs increases the intensity of an MVP. And I'll kind of go into why. How about Hokum? So with Hokum is its own entity as well. So this is kind of like you can't really memorize these maneuvers because like there's never like a oh it works for all of them. If you decrease preload, you'll actually increase a Hokum murmur. And if you think about it, again, how loud a murmur is tells you a lot about that murmur. So, what is making the murmur in Hokum? The murmur is being caused by, again, this blockage from this IV septum. This is blocking the outflow tract of the left ventricle. It's like flowing around it, and that's what's causing that murmur, right? So if I have less blood in the left ventricle, this IV septum has all the room in the world. It has, okay, it's like there's no blood in here. It can stick out all at once. It doesn't matter. It's actually going to make this murmur worse because now it's going to, like, there's going to be less space for that blood to go around. That's going to make it a louder sound. Okay. Versus if I have more blood, and we'll talk about this with like increasing of preload. But if I have more blood in the left ventricle, let's say I'm increasing preload, I'm increasing the amount of blood that's in here. It's going to push this septum out of the way, right? Because it's just there's more blood there. Everything's going to get squished. It's going to push this out of the way. And now there's going to be more space to move through to go out through the aorta. So more blood is actually better for Hokum. It actually forces the IV septum out of the way and then makes it less loud because, again, there's less of an obstruction. And again, we'll talk about MVP on its own. It's tricky. But just know pretty much MVP does the opposite of what you expect, which is great. Passive leg raise. So passive leg raise is literally this. You just raise the patient's legs. And the idea behind this, remember, you're trying to get that pooled blood in the veins. You're trying to get it to the head. So this is going to increase your preload. This will actually increase most murmurs, hopefully, again, making sense. You're increasing the amount of blood in the heart. There's now more blood that can bounce around, be turbulent, make noise. So technically, you would see a louder sound with a passive leg raise. However, with MVP, increased, if you increase the volume in the heart, you actually decrease MVP. Same with Hokum. If I have more blood in the left ventricle, I'm pushing the septum out of the way, and now I'm decreasing the obstruction, and now I can have a nice, easy track out. And then it's going to sound a lot like less loud. Okay. Rapid squatting. So literally, I guess what this guy is doing, which yeah, they totally do all the time, right, in the hospitals. But this would increase preload and afterload. So I think of it like when I'm squatting, I'm like pushing I'm pushing the blood from the veins up towards the heart, and I'm also blocking blood from leaving the heart. So I'm just overall increasing the amount of blood in the heart overall. That will increase most murmurs. It's the same as like the last one, but it will make MVP sound a lot better, and it'll make Hokum sound a lot better. Okay, so it's going to decrease, and it's kind of everything we talked about. I'm increasing preload, so I'm moving that septum out of the way, and then I'm actually increasing afterload. So if I'm increasing afterload, I'm still keeping more blood in this left ventricle. That's going to help move away the obstruction, and then that'll actually decrease the Hokum murmur. Okay. Oh, and then that is what I wanted to mention. With aortic stenosis, though, if I have aortic stenosis and then I increase afterload, it's going to make this stenotic murmur sound louder. So hokum, increased blood in the heart makes it better. Aortic stenosis, it makes it worse.
So like Hokum and MVP, they follow the same thing.
Yes.
Um,
Yes.
wait, why does MVP again like follow the same thing?
I think I have a slide on it. Let me see.
Okay.
Do I have a slide on it? Oh, maybe I don't have a slide on it. So with MVP, it's gonna go back to that. It's gonna go. Let's go back to thinking about that balloon idea of catching if I threw a water balloon to you. So with MVP, remember it's all about timing. So if I am so remember with the papillary muscles, it's like when the valves open, they open like this and they come back down. They open like this and they come back down. And what's causing that loud murmur is one of them stops prematurely, basically, and then that's your mid systolic click. Is from that chordae tendineae tensing up, and then it's tensing and it's just pulling on that valve, and that's causing that click. If you have more volume in the heart, so increased preload, if I have just more volume in the heart, think of it as like now I'm giving the chordae tendineae more time to close the valve. Again, just like catching a water balloon. If I threw a water balloon at you and you had more time to kind of cradle it, it's not going to be as loud as if I threw a water balloon at you and you just catch it and you just grab it and be like, okay, it's going to pop open. It's kind of the same thing. If I have less blood in the heart, that tensing is going to be a lot. It's going to happen quicker. Like it's just going to happen quicker because there's less blood there. It doesn't need to stay open for as long.
Makes sense.
Does that make sense? So it's kind of like I really like thinking about this water balloon for MVP because I think that's kind of what they're trying to get at with that sudden tensing of the chordae tendineae. Is like there's not enough time to properly close the valve because it's prolapsed back. So if you increase the amount of time it has more time to normally pull it down and be like in sync with the other one.
So that would probably cause like the snap to move like really far out, right? Like if there was a snap for MVP or click, a click.
Um, yeah, yeah. So the click would be later. I don't know if that's a thing. I know for mitral stenosis, the opening snap location can come up in vignettes. I don't know if they'll ever talk about the mid systolic click for MVP. But if that helps you think about it, yeah, for sure, because that's technically what's happening. You're giving the chordae tendineae like time to close the valve. So the click would be later, or it just won't be as loud. Cool. Okay. And then hand grip, it's a ridiculous picture, but hand grip, it's just an increase in afterload only. Um, this is since we're only increasing afterload, we're only increasing the amount of blood on the left side of the heart. So think about your left-sided murmurs, your mitral valve murmurs, your aortic valve murmurs. That's going to increase the sound of those guys. MVP is a left-sided murmur. It's on the left side of the heart. So we have more volume in the heart. The sound is going to be less because again, we have more blood in the heart. We're giving those chordae tendineae more time to catch that prolapsed valve. But increased blood on the left heart is going to increase the murmurs on the left heart because there's more blood there. So I listed them here: aortic regurg, mitral regurg, even a VSD would sound louder. Your exceptions are going to be hokum and aortic stenosis. Both of these are going to have decreased sounds. And again, because of what we just talked about, if you're allowing now there to be more blood in the left ventricle, it's going to be easier for hokum to push this out of the way, and it's going to be easier for aortic stenosis to push through the stenotic valve. Okay? Does that make sense? So once we have enough pressure, enough blood in the left ventricle, we can push through the stenotic valve here and through like this bulging area here. And again, what's causing the murmur in aortic stenosis is trying to push blood through a stenotic valve. If I have more blood, it's going to sound lower. It's going to sound not as loud. Same with this. What's causing the murmur is the blood flow around this IV septum. If I push it out of the way because I have more blood there, the murmur is not going to sound as loud because it's the obstructions like out of the way. And then inspiration, so just breathing in. Literally breathing in is apparently a maneuver. Who knew? But inspiration helps you with your right-sided murmurs. And again, this is like a very, first year physiology concept is when you breathe in, think of it as like you're sucking the blood from the veins into the heart. So it's going to increase the preload because you're increasing that venous return. Sorry, it's not preload. I'm increasing venous return. I have to remember to not do that. You're increasing venous return to the right heart and you're decreasing venous return to the left heart. Because again, when you're breathing in, it's almost like the right atrium becomes a vacuum and it just sucks all the blood.
I've like always used those words interchangeably, like preload and like
Oh,
VR.
really? I
Yeah.
used to, and then I like had to train myself to stop doing that because I was confusing people. Preload is specifically talking about like the left ventricle. So it's like if I have more blood going to the left ventricle, that's increasing the preload. Venous return is I mean, they kind of are similar, but preload is again specifically talking about the left ventricle. So you would be wrong here if you used it. Usually you can use those two interchangeably, usually, because the amount coming in for the venous return is the amount going to the left ventricle, right? So technically, like your venous return is the same as preload. But in this instance, when you're kind of creating a vacuum in the right atrium, they're not the same thing because you're just increasing venous return to the right heart and you're decreasing the amount that's getting to the left heart because it's just the right atrium's holding on to all of it. So that will increase right-sided murmurs and then decrease left-sided murmurs because again, more blood on the right side, less blood on the left side. So it's going to follow that same pattern. If there's more blood, it's going to be more. If there's less blood, it's going to be less.
Like, why does inspiration lead to that though? Like, why does inspiration cause
I
less
don't think
blood
this
on the
is
heart?
true. I like don't think that this is a real one, but this is pretty much the only way. This is pretty much the only maneuver that they can use in a vignette to talk about a right-sided murmur. And they'll even say like, "Oh, if I have the patient inspire and then the murmur gets softer or gets lower, you know it's a left-sided murmur." So if you're between like tricuspid regurg and mitral regurg and you have no idea which one it is, and then they tell you that, you can figure out between those two. But again, I don't think this is actually a thing. I think it's just a way to differentiate in vignettes. Okay, so just like you said, Hokum and MVP follow the same thing, different reasons, but they follow the same weird constructs. So Valsalva or standing, so this is going to be your decrease in preload, is going to increase the intensity of Hokum and MVP. If I'm decreasing preload, I have less blood in the heart. So if I have less blood in the heart, I can't push that IV septum out of the way. It's going to make a louder murmur and I'm going to give my chordae tendineae less time to grab the prolapse valve. It's going to make it sound louder. Squatting, passive leg raise. So squatting increases preload, increases afterload. And then passive leg raise increases preload. Um, that's going to make these softer because again, it's the amount of blood that's basically in the heart increases. So you can push the IV septum out of the way. You have more time to like grab that prolapsed valve. So the both of those murmurs are going to get like softer. Oh, I knew I put a slide in. Knew it. So this is what we talked about. If you have decreased preload, why do you have an increased MVP? Again, chordae tendineae, that's your mid-systolic click. That's what's causing that mid-systolic click is this chordae tendineae like catching that mitral valve and snapping on it. If you decrease the preload, it's less time. Wow, I even put the water balloon in here. Killing it. So again, it's like there's less time for it to catch the valve because there's just less blood there. So it just closes sooner than it needs to. And then that's why it gets so much louder. It's like it just sounds more intense. It's because you don't have enough time to like bring that valve down, like the prolapse valve down to the normal valve. And then the opposite, if I have increased preload, I have more blood in the heart. That means I have more time now to catch that prolapse valve. And then it's going to sound a little softer. Okay, let's do some questions. I know you probably did so many questions today, but do you have questions before we do a few that I think are important, at least?
No, I just asked them throughout, which is so helpful.
Good. Okay, good. Yeah, ask him now too.
Wait, I have a question
Yeah.
actually. So for the exam, just because like all the questions I've been doing are just random UWorld, but so many of them like we covered today. So like for the exam for PBL, is it going to be like a lot of repeat, not like same questions, but like is it going to be similar where there's still going to be a lot of phys and like all this stuff on it too?
Oh yeah. Oh yeah. Yeah, you're this is a really good exam. Like this cardio-renal pulm exam second year is the I think it's the best exam of second year just in terms of like it's a well-written exam. It's actually like a very good exam. So if you like feel like you've covered the content and you're like you don't have to be doing amazing on the practice questions, but if you just feel like you know enough that it's like okay, I know this decently well, you'll probably do well in the exam.
So
But
like
this
phys also comes up.
Oh yeah, that's why I always tell people like review your phys at the beginning of the block because it's going to come back up in some way, shape, or form.
Okay, got it.
And like don't forget farm, don't forget micro, like that stuff's all going to come on as well.
I've been doing like two micro or no, two farm a day. I did all the bacteria and viruses, but I haven't done any of the stuff yet.
Okay. So you have you do you have my thing that I sent?
Yeah, I just haven't looked at it yet.
No, it's fine. Just go through it and like make sure you're covering all the ones that I at least say to cover in cardio, renal, and pulm.
Okay.
Especially if you're pressed for time. Like just I would just focus on those guys.
Okay.
Okay. All right, you got to think about this one. This is the thinker. Tell me first what do you think this patient has before you answer the question.
Well, I thought they had like um aortic stenosis.
Good. Perfect. Aortic stenosis. So remember, old people are sad. So we have an old guy, and he has syncope. He has angina. Or does it say that? Yeah. Angina, and then dyspnea on exertion, which it doesn't really say, but that's kind of the same thing. Okay. And then crescendo, systolic, crescendo, that's aortic stenosis. Perfect. So here's the thinker part.
Well, you could have a history of rheumatic fever, right?
Um,
Like if you have recurrent rheumatic fever, can't you also, but okay, maybe not. I'm just gonna read the other ones. Well, I'm gonna cross out D.
okay.
Delayed carotid upstroke, endocard. Um, maybe like I don't know. Is it wait aneurysm? Maybe
This is
like
a
the
hard
aneurysm.
one. This is hard.
With the endocarditis, like I don't know. I kind of never know with these questions.
Okay. So for this one, you did the right thing. Rule out anything that you at least know for sure is not correct. IV drug use, we talked about. That's going to be a right-sided murmur. That's going to be something like tricuspid valve. That's not going to be this guy. Fine. Out. It's out. Aortic aneurysm, you typically don't like have I mentioned anything about aortic aneurysms with aortic stenosis? No. Like you typically don't see aortic aneurysms with aortic stenosis. Typically with aneurysms, it's like you have like a defect in the wall it's of the heart itself, and that's what's causing like the aneurysm. Because with aneurysms, you need, and I don't know if you remember this from like Pathoma, chapter 7, you need like a defect in the wall in order to even have an aneurysm.
What was the thing that you were saying with like you can get regurgitation? Like what is the condition that can cause that?
So aortic and mitral regurg is your acute rheumatic fevers.
Oh, got
Um,
it. And the
and
syphilis, right?
then your mitral stenosis is your chronic rheumatic fevers.
Okay, got it.
Out. I mean, you can keep it like this is like if you kept that one, that would be fine. Because if you're like, oh, I don't remember if it was aortic stenosis or if it was aortic regurg. This is more so your aortic regurg, mitral regurg, but we can leave it. Endocarditis, I mean, it can affect the aortic valve, but usually not. This is like an infection of the valve. It's just blood is flowing way too fast through the aortic valve that bacteria can't really even grab it. So, like, typically you don't see endocarditis of the aortic valve. Endocarditis more so affects like the tricuspid or the mitral valves. So this one is actually delayed carotid upstroke. And if you're like, why is that the answer? What are the three branches of the aorta? You can
Um,
do it.
the carotid, the brachiocephalic, and the subclavian.
Mm-hmm. Good. So let's just, I mean, we'll just do this one as carotid. So this is your carotid. It's one of the branches of the aorta. Here is your aortic valve down here, and it's stenotic. So blood's trying to come through here, but it takes a little bit longer to push this open. That's what that crescendo decrescendo is. The crescendo part is trying to open that valve, and then eventually it does, and that's your decrescendo. So, if in a patient that has no aortic stenosis, blood's going to flow from the left ventricle through the aorta, and then it's going to go up through the brachiocephalic, up through the carotid, up through the subclavian, left subclavian. But now, if I have a stenotic valve, it's going to take a little bit longer to open this, even if it's only like a millisecond or two. It's going to take longer because it's a stenotic valve. You need a little bit more pressure to open it. So blood is still going to flow through these branches of the aorta, but it's going to take longer. It's going to take longer until it normally gets there. That's your delayed carotid upstroke. They could have called this delayed brachiocephalic upstroke, delayed subclavian upstroke. It's just going to take longer because we have a little delay from having a stenotic valve.
That makes sense.
Is that cool? So he kind of talks about that. Um, Clinical findings, delayed and weak carotid upstrokes, resistance to flow across the stenotic valve causes the upstroke of the carotid pulse to slow. In addition, it's weak. These findings can be appreciated by palpating the carotid. It's basically just like it's going to take longer to get blood through there because there's a stenotic valve. Okay. Um, Everything we talked about. So endocarditis most often leads to regurgitant lesions. Rheumatic fever can develop rheumatic heart disease decades after. While any valve can be involved, usually mitral is infected, and the most common lesions are mitral regurg or mitral stenosis. Rheumatic fever is a very rare cause of aortic stenosis, and aortic valve disease typically only occurs in conjunction with mitral disease. Okay. Okay. Are you good with that question? So see, this is a very like boards. This is like a very boards question. Like your exam would just be like, what is this murmur? Like literally, what is this murmur? Or what's the cause of this? Like, what's the cause of this? This is like taking it a step further. Like, you know, it's aortic stenosis. Now it's like, okay, what else would you expect to see? Oh, the one of the branches of the aorta is the carotid, so it's gonna be a little delayed to get blood through there. Delayed carotid upstroke.
I don't know if this is like something I just need to do on my own, but like sometimes like when I'm learning everything, like I get what's happening, but I never, it's like confusing to know like what's first and then what's secondary and what's like after that. You know what I mean? Like how so many of these conditions are like one after the other.
I think you should watch Dr. Ryan's Boards and Beyond videos for cardio. I feel like I had no idea what was going on in cardio until I watched his videos. And I feel like I literally became like a cardio like wizard after I watched all of his videos. He's just so good at explaining it, and especially in that time-wise manner, which I think is what you're struggling with.
Hmm.
I literally did not understand cardio at all. And then he really, I'm telling you, he does such a good job at kind of walking you through it in that like time. So in your head, it makes a lot of sense. Okay. And like I told you the last time, it's not gonna be a waste of time. You're gonna have so many cardio questions on your exam on board. It's not gonna be a waste of time, and you'd rather do it earlier than later.
I'm trying to watch like one day.
Okay. Yeah, I would just hammer those out. Hammer those out. Maybe cut back on the questions a little bit because I think it'll really help you to kind of hear him take you through it. And I think then you'll start even doing better on questions.
Okay. So cardiac apex is telling me that it's going to be like a mitral issue.
Okay.
And then hollow systolic, um, so systolic murmur. So it would have to be like, um, so systolic murmur, it would have to be like, maybe like, could it be like mitral regurgitation?
Mm-hmm. Good. So you know it's the mitral valve. And then it's telling you it's during systole. So what's the mitral valve doing during systole? It should be closed, but if there's a murmur, that means it has to be a regurg murmur. It must be. And remember what I told you with this is what I told you was going to come up with mitral regurg, ischemic cardiomyopathy. That's literally one of the causes of mitral regurg. You lose that posterior papillary muscle. It just loses its blood supply, and then you get it just stops working. And that's another. So that's like kind of like a way to check yourself. Like, okay, yeah, this is mitral regurg.
So is that posterior, like that muscle, is that the one? Because I remember one question talking about how one of them has like a dual supply and one of them only has one.
Yes. Yes. So the anterior is supplied by both. The posterior is just the RCA.
That makes sense. So hand grip maneuver. So you'd be decreasing blood flow back.
So hand grip, what is this? What is hand grip doing?
It's increasing like resistance, like increasing afterload.
Hmm.
And then it
So if
would
I'm increasing afterload, is that increasing or decreasing the amount of blood in the heart?
that's increasing the amount of blood in the heart.
So if I
So
have
that
more blood in the heart, would that increase or decrease a mitral regurg murmur?
it would increase.
Hmm. Perfect. So kind of see the stepwise of how you kind of like answer these types of questions. Yeah, perfect. So this is a left-sided murmur. If I'm increasing the amount of blood on the left side of the heart, yeah, it's going to increase the sound of it. For again, for most murmurs, if there's more blood in the heart, it's going to get louder. Cool. Perfect. All right, and just let me know when you're ready to see the Wiggers diagram.
So it's like something that's also, so like if you need two pillows, like does that mean that it's like a left-sided issue?
Yes, very good. So that they call that the pillow sign. You'll actually probably start doing that with your patients. Like when you do like your SPs, you'll ask if they sleep like with how many pillows they sleep with at night.
Okay.
And it's
Because
just to
I
kind
got
of get an idea of like how much is their heart failing, basically.
like, okay, so actually, I had a question today about
Mhm.
this, like that they were having trouble, like the same thing as this guy, but like I thought that that meant like that there was pulmonary issues. Like I didn't realize
I know, I
that.
think everyone thinks that. I actually am so glad you got a question on that. Everyone thinks if they sleep up with pillows that it's a pulmonary issue. But it's not. This is a left-sided heart issue and it's basically like if you have heart failure, for example, and you're like laying flat, all the blood's going to just like stay in the heart and then it's going to basically like leak back through like into the lungs. It's going
So
to go
like,
left heart to right heart to lungs, and then that is like that's where it causes like your crackles. It's like your heart failure signs sound like pulmonary issues, like you have crackles and edema and stuff like that.
but like, why can they not like sleep like unless they have two pillows? Is it because of like the pulmonary, like they're having trouble breathing secondary to the left issue?
Yes. Yes. So it's kind of like if you're laying flat on your back, um, the heart is now like gravity is now like pushing down on the heart, like making it harder for the heart itself to pump blood against the gravity. Okay? Because it's all just kind of like sitting down, and then more of it kind of like is now staying in the heart. So they can literally assess heart failure with how many pillows someone sleeps with. So this is only two pillows, so that's not that bad. Some people are like, "Oh, I need to sleep with five pillows. Like I need to be like literally almost like vertical to be able to sleep at night because it takes pressure. It basically is taking pressure off of the heart in that regard. So it just makes it feel like that they can breathe better.
So
And
like,
I'll
are there
see if
any
yeah, go ahead, sorry.
Sorry, I was just wondering, like, is it just rare, or like, is there any like, if you have any like palm issues, like, can it still lead to the same issue if it's like just isolated to like a lung issue?
Usually not. Usually if you have to sleep up with pillows and you have the shortness of breath thing, usually that's like a heart issue.
Okay.
Usually. And that's why like I remember too like they'll say something like this and then they'll talk about lung symptoms and they're doing it on purpose to try and get you to think it's a right-sided issue. It's always, always, always a left-sided issue. It's always a heart problem. So like they'll barely ever talk about the heart. They'll just talk about like, oh, like I heard crackles when I was listening to the lungs. You're like, oh, there's a lung problem. Crackles is always going to be heart failure, and it's like leaking back. That's always what's going to be causing that shortness of breath.
That makes
But we'll go.
sense.
I'll look at, and like after this question, I'll look to see what the Amboss question says. Maybe they also give some insight on this.
Okay. I think I'm ready to see the diagram.
Okay. Yeah, no, we didn't really talk about Wigger's diagram at all, but any idea just from looking at this what looks a little off? I don't even know if you've looked at Wigger's diagrams recently.
I remember I did so many LIs last year that I should know. Like I should know what's wrong.
Okay.
But I don't oh, is it like the left ventricle, like how it goes up like that?
Left vent. So this dark gray is the aorta. This is the left. Oh, you mean over here? No.
Or no, the left atrium I meant.
Yes.
Like this slanted, like
Yes.
okay.
So if it's going, so left atrial pressure should usually stay like right here. So now it's really high. So what would that tell you if my left atrial pressure is a lot higher where it overlaps with the left ventricular pressure?
Like wouldn't that be like regurg? Or something's like getting pushed back?
Okay. All right. So keep that, let's just keep that in mind. So my left atrial pressure is really high, not consistent. So that's another thing to look at with this. Is it only high where it like overlaps with the left ventricle, or is it high always? Like, is it up here and it just stays here, or is it only high for where it needs to basically open that ventricular valve?
Well, it's like gradually increasing, right?
Okay. So, I mean, do you want me? So you'd have to kind of now pick based on the murmur that it is. So I think I want to tell you what the murmur is so that I can see if you can pick it. But with these, and this is again, you know it's an atrial problem. So now you're like, okay, is it atrial like is it mitral regurg or is it mitral stenosis? And with these, how I kind of look at it is so the left atrial pressure increases, 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 and then it gets to a point right where the ventricular valve opens. Basically, it's like right around here, the left ventricular valve, and then it drops off. And it doesn't remain high after that either. It drops all the way back off. So that tells me this is like not, it's like the pressure isn't high because there's just a lot of volume there. The pressure's high because it's pushing against something. Like it is trying to push against something.
So, and would it be stenosis then?
Um, Hold on. Now I'm confusing myself. No, wait. Yes, wait. What are these? Because I didn't see stenosis as like one of the stenosis as an answer. Oh, maybe I'm wrong. Maybe I need a course in this
It's like so
again.
confusing, Wiggers.
Yeah, this is regurg, but hold on. Mitral regurg. Rapid increase in left atrial pressure during systole. Left atrial pressure. Oh, you know why? Because that's not where the left ventricle opens. This is where the aortic valve closes. Yeah. It's just me being silly. Just me being silly. Yes. So sorry I gave that away, but it was good. We all learned. But this is gonna be, yeah. So that's another thing with Wiggers is to go on here and characterize where systole and diastole are. Because something like mitral regurg and mitral stenosis, one is occurring in systole, one is occurring in diastole, right? So if you can identify where that murmur is on here, you can basically figure out, yeah, what the murmur is. So my mitral regurg is during systole. That's where you would see that increase in pressure. So that would tell you, like, yes, there is an increase in systole and diastole. It's pretty much back to normal.
Do you know like where like are there like images where it'll show you like what the Wiggers will look like during different dysfunctions?
I think I did put one, two, three more Wiggers diagrams in here. I would say maybe Amboss would have, because these are all from Amboss. So I would think that Amboss, like just their normal pages, would have pictures of all of the pathology states.
Okay.
And then yes, so then here is your the entire Wiggers diagram. Okay.
So it's heard after S2. So S2 would mean wait, no. It would mean aortic and pulmonic valve closing, right?
Yeah, so is this diastolic or systolic?
This would be the this would be diastolic.
Mm-hmm. Good.
And then um
So what you can do, and this is like just a tip for exams too, if you get to this point where you're like, yeah, I know that this is 100% a diastolic murmur, go here and cross off any of the ones that are not diastolic murmurs before you even do anything else.
so aortic stenosis can be crossed off, the mitral regurg and tricuspid regurg. And then so the murmur is lowest. Wait, so the person inspires. So they breathe in and the murmur increases with intensity. So that tells you it's a right sided. So then it would have to be so it would have to be D.
Good. Look how easy.
Like, are they trying to throw us off with like the left sternal border? Or is left sternal border always
No,
tricuspid?
that's also like another name. I'm gonna go all the way back. It's really annoying, but where's left sternal border? So here is your tricuspid area. Technically, technically, I had to look at this too. Technically, that's the left sternal border.
Okay.
Just because of how the heart is like facing in the body. Remember, the right ventricle is sticking up right along the sternum, like anatomy wise. So the tricuspid valve is like right there.
That makes sense.
That's why these landmarks are a little tricky. Like even the pulmonic valve is on the left side when you hear it. It's just because of the how the heart is like how it's like placed in the body. Oh, that one. Okay, good. Awesome. Okay, and then let me know again here.
I feel like I didn't even get anything from this question stem. Like, was I supposed to know?
Well, if I told you a 62-year-old man comes in, he's shortness,
Oh,
yeah, he's short of breath, episodic chest pain.
wait, actually, no. Wait, I was thinking like like the aortic stenosis.
Hmm. That's what I would think of when I have like an older man that comes in with like shortness of breath during exercise, chest pain, stuff like that, like dyspnea on exertion, angina, syncope. I would think that. So left-sided murmur, and then, but you're not supposed to get anything really. But like if you're thinking aortic stenosis from that, that's fine. Now they give you the actual Wiggers diagram.
So, oh yeah, so the left ventricle has to like increase its pressure so much. So it is aortic stenosis.
So now go back to the question.
The intensity of the cardiac murmur. So the cardiac murmur is like the most in the middle, right? Because it's like it like increases. So then would it be the most at like B?
Yes. Very
Yay.
good. But you also have to remember too, like, I mean, this one was not easy, but this was like we had talked about this so much. It's during systole. So you have to mark on here, okay, where's systole? Like if it was a diastolic murmur and it got louder at the beginning, it would be D. You know what I mean? Like it's kind of like you have to figure out using Wiggers, like, oh yeah, systole is here and then diastole is afterwards. But
Did you
aortic stenosis, crescendo, decrescendo, it's going to be loudest in the middle of systole because of that crescendo.
did you get like a lot of wiggers on your boards?
I had like two, not crazy. You would probably see this more on your exam.
Okay.
Oh, we did this one. Okay. Beautiful. Beautiful. Here's a graph of aortic stenosis. Here's this one again, because I just like seeing the systole diastole.
So systole. So I see click. So would that mean MVP?
So, not always, not always, um, because MVP is a systolic murmur, right? So this
Yeah.
is saying there's a systolic ejection click and then a blowing diastolic murmur.
Would that be like the PDA?
No,
Oh.
that would be, I mean, that's a good thought. I actually don't know why they say the systolic ejection click.
So would
Um,
this be like, so let's think, like blowing, would that be like one of the VSCs or like the ASC?
no, because again, systole, right?
Yeah.
When I get stumped like this, I look at the question they're asking me and I'm like, okay, why would they be asking me this question? What murmur could they be talking about? So if they're asking me about pulse pressure, what murmur do you think that they would maybe be asking about?
Oh, like the maybe like, well, could it be like regurg maybe?
Which one?
Aortic regurg.
Yes. Yes. So that's how I would approach. I actually don't know why they explain this murmur like this. I forget, I'll look in the explanation. But if they're asking you about pulse pressure, just kind of think about maybe this is aortic regurg, honestly, because that's the only one where pulse pressure is like relevant.
Okay, that makes sense.
I know that's kind of like a cop out way to answer questions, but I mean, you got to do what you got to do.
I like completely forgot that blowing murmur is like aortic
Yeah,
regurg.
you do. You do have a blowing diastolic murmur because again, I mean, I don't love blowing. I think more, I mean, you do have a blowing murmur for aortic, but you have blowing murmurs for other stuff too. Aortic, I think mitral regurg, you can also have a blowing. I mean, I know it's hollow systolic, but it can also sound blowing. So it's kind of, this is a really poor way to talk about aortic regurg, but you see pulse pressure, you're like, all right, it's probably aortic regurg.
I need to start doing that with questions.
It really helps just kind of like what are they trying to get at? Like what do they want me to get out of this question? So if they're asking me about pulse pressure, they're probably asking me about aortic regurg.
So like, um, would it be B?
Yeah, awesome. But let me see what they say about this. Aortic regurg from a bicuspid aortic valve. Bicuspid aortic valve causes that systolic ejection click. That's dumb. So that's tricky. I don't think they would do that to you, like for your exam. Maybe on boards, but not on your exam. That's tricky. They would just give you like a blowing diastolic murmur, like a blowing decrescendo diastolic murmur. I think they would actually give you. Um, yeah, bounding pulses. That's another like buzzword that you can hear for that. Yes, this is your pulse, your widened pulse pressure. So the increasing systolic pressure and then really really low diastolic pressure. That's your widened pulse pressure.
Are there any other conditions that will cause that, or is it mostly for
I
regurg?
think really only aortic regurg. And again, I think it's because the aorta has such a high pressure always anyway. So now if I'm increasing the amount that I'm pumping out with each beat, because some's leaking through, and so I'm increasing the amount going through, and when it's resting, I'm losing blood. It's going to increase in one direction, decrease in the other direction. That's like very characteristic of aortic regurg.
That makes sense.
And then apparently the head bobbing is called de Mosset's sign.
I didn't even know that like you would see like
Head
remember
bobbing?
how
Yeah.
yeah, well I've seen them in problems now, but then like the nail bed thing.
Oh yeah, yeah. I mean even Dr. Ryan says here like it's low yield to memorize these. Speak for yourself. Yeah, he's like, these are largely historical findings from before heart surgery was available. But you might still see it. Like, you really might still see it in there.
Yeah.
Okay, one more. So, really quick, what are you thinking?
Aortic stenosis.
Very good. See how they talk about aortic stenosis? It's always the same thing every time.
Wait, you know like how they have like 2 out of 6, 3 out of 6.
Yeah,
Are those, do those actually give you anything for the
it doesn't really
problem?
matter. It just tells you how loud is it. Like if the loudest, like a 6 out of 6, they say it's like you can put your ear up to the chest and hear it. A 1 out of 6 is like you can barely hear it with your stethoscope. So like it kind of tells you how loud it is, but it doesn't really mean much. It doesn't really matter.
Okay.
So like if they say like a 3 out of 6 crescendo decrescendo, this is like loud, like I can probably hear it nicely with my stethoscope, but I need my stethoscope to hear it. I can't just put my ear up to the person's chest and hear their murmur.
So the murmur intensity will, what will happen if they stand? So if they stand and this decreased pressures, then that would be decrease.
So decreasing preload, yes, it will decrease left-sided murmurs. Amazing.
Oh wait, you know for like LIs, like would it be bad if I repeat some of my other LIs?
From like, let me stop recording.
Like